Welcome to the deep dive. We take complex topics, look at the sources, and really try to give you the essential truth. Today, we are wading into, well, let's be honest, one of the most persistent debates in the U.S. universal healthcare, or UHC. Now, UHC, it's almost always framed as, a moral thing or a political football. But for this deep dive, we're kind of setting those usual talking points aside. Our mission is to look at the data, the cold, hard global economic receipts, and then crucially, confront why the U.S. has resisted it. Because, as we'll see, it's not just about, say, small government ideas. It's deeply, deeply tied to systemic racism.
That's absolutely right. And it's a necessary analysis, especially because, well, first we have to be clear on what UHC actually means globally. The perception here can sometimes be that it's like one single government-run system. But that's really not the case most of the time. The World Health Organization defines UHC pretty simply. It's guaranteed access to the health services you need, prevention, treatment, rehab, the whole lot, without facing financial hardship because of it. And, this is key, it does not always mean full single payer, like, Canada's core system.
Right. That's a really important distinction. So what are some common ways other high-income countries do it?
Well, there's quite a bit of variation. Look at Germany, for instance. They use mandatory sickness funds, right, with competing private insurers. But the government mandates really comprehensive coverage.
Okay.
Then you've got the UK, which relies heavily on the NHS, nationalized hospitals and services.
See, the NHS.
And France, Japan,
Yeah.
they use similar social insurance models. The point is, the structures vary a lot, but they all share that one basic principle.
Yeah.
You get care, and you don't go broke because you got sick. The U.S. is just the dramatic outlier among wealthy nations there.
And what an expensive outlier we are. Let's jump right into those numbers because they are frankly shocking. We're paying double the global average for less. So U.S. health spending in 2023, our sources put it around $13,400 per person.
Per person. Yeah.
Now compare that to our OECD peers, other wealthy countries with UHC, their average spending, about $7,400 per person.
Right.
It's roughly half of what we spend. Half.
And just to give that some more context, the next most expensive country, Switzerland. Still thousands cheaper per person than us. Thousands. And here's the kicker. That incredibly high cost, it just doesn't translate to high performance. We pay the most, by far, yet our health outcomes generally worse.
Can you give us some specifics on those outcomes, the hard data?
Sure. Well, life expectancy is a big one. Stark difference. U.S. life expectancy was around 78.4 years. Compare that to about 82.5 years in similar rich countries.
4 years, that's significant.
4 years longer if you live in France or Japan or Australia.
Yeah.
And another comparison recently showed the U.S. ranks near the bottom, like dead last among wealthy nations in preventable deaths.
Preventable deaths.
Yeah. So objectively, other countries spend less, often much less, and their citizens live longer, healthier lives.
It's just a terrible return on investment, isn't it? And for people here, this failure isn't just an abstract number like life expectancy. It's financial trauma. This is the part of our system that just doesn't exist at that scale in UHC nations. I mean, think about the individual impact. About 2/3, 66% of personal bankruptcies in the U.S. point to medical bills or losing income from being sick as a key reason.
66%.
We're not talking about, luxury spending. This is middle-class families. Their kid needs an appendix out. They hit a huge deductible, maybe $10,000.
Right.
And suddenly they're choosing between paying that medical bill and, I don't know, their car payment or their rent.
And that vulnerability, it hits everyone. It's not just the uninsured, though they're obviously hit hard. We're talking an estimated 100 million people, maybe more, in the U.S. carrying medical debt, often people with insurance, middle-class families.
Yeah.
So that medical debt becomes this sort of invisible tax just for getting sick. A tax that, again, you just don't see at this level in universal systems. If you step back and look at it purely from like a return on investment view, the U.S. system is just massively underperforming compared to basically every other major industrialized country. Germany, Canada, they spend way less per person.
Okay, so we've established the system is financially disastrous for individuals and inefficient overall. But let's flip this. What if guaranteeing health care isn't just, the right thing to do morally, but actually a really smart economic strategy? Let's unpack that argument for UHC as being pro-business, pro-GDP.
That's the key pivot, I think.
Yeah.
Because when people can actually afford a basic care, preventative stuff, chronic care, checkups, blood pressure meds, asthma inhalers, they stay functional. Better health means fewer missed work days, obviously lower absenteeism, but crucially, less Presenteeism.
Ah, presenteeism. That's when you drag yourself into work even though you're sick and you basically just underperform all day.
Exactly. You're physically there, but you're not productive. And that cost is huge, but it's often hidden. One study we looked at found that this lost productivity from presenteeism cost employers over $3,000 per worker per year.
Wow. Per worker.
Per worker. That's often more than the direct medical costs employers pay for many people. So universal access to primary care. It helps manage chronic conditions like diabetes, hypertension, things that drive that low productivity. Healthier people are just, well, better, more reliable workers. Simple as that.
Okay, but hold on. The counter-argument you always hear is, well, UHC means bureaucracy, government control, longer wait times. Wouldn't that hurt productivity? How do these other countries handle access? And does it cancel out the savings?
That's a really fair point. It comes up a lot. It's true that for some highly specialized care, systems like the UK's NHS might have managed waiting lists. But here's the flip side. Access to primary care, the everyday stuff, is often faster and cheaper in UHC systems precisely because cost isn't a barrier. In the US, people delay basic care because they're worried about the bill. So UHC actually pushes towards early intervention. That prevents the really expensive catastrophic health events, the stroke, the heart attack, which are the real productivity killers. Prevention is almost always faster and definitely cheaper than ending up in the emergency room.
That makes a lot of sense. Okay, let's talk about the employer burden then. I've heard this analogy of an invisible payroll tax. What's that about?
Yeah, it's a good way to frame it. The current U.S. model, where employers are the main providers of insurance, it acts like an invisible payroll tax. Hiring someone means taking on these extremely high private insurance costs. It just inflates the cost of labor for businesses just to cover a basic human need. In UHC countries, that cost is socialized or spread out across society.
Yeah.
It effectively makes healthcare part of the national infrastructure, like roads or bridges.
Okay, interesting analogy.
Yeah, I mean, you don't negotiate road coverage for every new employee, right? You just use the road system that's there for everyone. Why should basic health coverage be so different?
So the argument is that these huge private insurance costs are basically hiding an inefficient infrastructure costs that businesses in other countries just don't have to deal with in the same way.
Pretty much. It shifts the whole perspective.
And it also traps people, right? This idea of job lock.
Precisely. If you or someone in your family has a pre-existing condition, a chronic illness, you simply cannot risk leaving a job that has good benefits. Even if that job is terrible or stifling your career, that lack of labor mobility, it holds back innovation. It stops businesses from getting the best talent because people are stuck.
And the flip side of that is the debt drag we talked about earlier.
Exactly. When households are buried under medical debt, they become risk-averse. Forget starting a small business.
Right.
They spend less in the general economy, to fewer trips to local shops, fewer services bought. It slows everything down. And this medical debt burden, it disproportionately hits Black and Latino families, making existing wealth gaps even wider. It acts as this constant economic headwind for huge parts of the population.
So UHC isn't just about treating sickness, it's about preventing economic stagnation caused by sickness and the fear of its cost.
Yeah, it reduces what you could call crisis medicine. That's the most expensive way to deliver care.
Yeah.
Instead, you steer people toward early, cheaper treatment. You avoid that $50,000 ICU stay or those late-stage cancer treatments that, let's be honest, often end up getting paid for anyway, whether through ER write-offs, hospital charity care, or taxpayer-funded Medicaid after someone's wiped out financially.
It just seems so economically irrational for the U.S. to keep doing this. Which brings us to the really big question, doesn't it? If the economic case seems so strong, or at least very compelling, why has the U.S. resisted UHC for, nearly a century now? It feels like there's more to it than just dollars and cents.
There absolutely is. The resistance historically hasn't been primarily economic. It's been political and deeply intertwined with race. When the U.S. was building its modern social safety net, these programs weren't really designed to be truly universal from the get-go. They were often racially structured right from the start. And that fundamentally weakened the whole idea of a shared benefit for everyone.
Okay, let's unpack that. Give us an example. The New Deal in the 1930s.
Exactly. Look at Social Security. Cornerstone program, right? But initially, it deliberately excluded domestic workers and agricultural workers.
Okay, why those groups?
Well, think about who held those jobs, especially in the South back then. Overwhelmingly, it was Black Americans. So by excluding those job categories, the program immediately baked in racial inequality. It set a powerful political precedent. Major federal programs could and would leave certain groups behind. It undermined universality from day one.
So it created a sort of segregated welfare state.
That's a good way to put it. And you see it again, maybe even more starkly, after World War II with the GI Bill.
Right, the GI Bill helped build the white middle class massive opportunities.
Massive. It was arguably the single biggest engine for white middle class wealth creation in American history. But black veterans, they were systematically denied access to those benefits.
How? It was federal, wasn't it?
The bill was federal, but its administration was local. And local administrators, particularly in the South, but elsewhere too, used racist practices to deny black veterans federally backed home loans, educational opportunities. The works.
And that denial connects directly to the racial wealth gap we still see today.
Absolutely foundational to it. And critically for our topic, this pattern immediately spilled over into healthcare. When the first serious proposals for national health insurance came up in the 1940s and 50s, who fought them tooth and nail? Southern Democrats, the Dixiecrats.
And they weren't just fighting against big government in general.
No, not just that. Their specific fear, stated quite openly sometimes, was that federal health programs would come with non-discrimination clauses. Meaning they would undermine segregation. Jim Crow, particularly in hospitals. They knew that if the federal government started funding hospitals significantly, those hospitals would eventually be forced to treat black and white patients equally, maybe even in the same wards.
Wow. So blocking universal health care or federal involvement in health care was an explicit political strategy to maintain racial segregation.
It was absolutely central to maintaining segregation in that era. The result is that the U.S. health system didn't develop as a unified system. It developed along racially unequal lines. You got one system, largely employer-based private insurance, for the mostly white, middle, and working class. And then you got a fragmented, chronically underfunded patchwork system for everyone else, people of color, the poor, the elderly, before Medicare. That fragmentation wasn't an accident. It was, in many ways, the goal.
And this historical structure, this deliberate fragmentation, it then fueled the political strategy of racializing government aid itself, didn't it? Making people suspicious of it.
It absolutely did, starting after WWII and really ramping up later. Politicians and parts of the media very successfully framed government aid, anything that smacked of socialized programs, as primarily benefiting black people, often at the expense of hardworking white taxpayers.
That narrative.
It was a deliberate and incredibly effective political tactic to build popular resistance against any kind of shared universal benefit program, even ones that would clearly help many white working-class people too.
And we saw that perfected almost with those incredibly damaging and misleading welfare queen narratives in the 80s and 90s.
Exactly. Those myths successfully poisoned the well. They made it politically toxic to even propose universal programs by constantly framing potential recipients as somehow undeserving, often using racist dog whistles.
So that history explains why the U.S. system is so fragmented today. It's a legacy system.
It's a direct legacy. Remember how Southern segregationists fought for decades to keep federal power weak, especially concerning social programs?
Right.
We ended up with healthcare being heavily controlled at the state level. This patchwork system, political scientists sometimes call it racialized federalism.
Racialized federalism. Can you define that a bit more? Is it basically using states' rights as a tool to block programs that might disproportionately benefit minority groups?
That's a very sharp way to put it, yes. It allows state-level politics, often influenced by racial dynamics, to override or block federal initiatives aimed at creating more universal standards or benefits.
And you argue we still see this playing out.
Look at the Affordable Care Act's Medicaid expansion. Most of the states that refuse to expand Medicaid, leaving millions of their own working poor citizens uninsured, are where?
Mostly in the South.
Mostly in the South.
Yeah.
States with higher black populations, states with that long history of Jim Crow resistance to federal programs.
Yeah.
Is it purely a coincidence? Or is it a clear continuation of that same political dynamic, using state control to limit access for certain populations?
It's a chilling continuation, and it shows how systemic racism doesn't just block UHC as an alternative. It actively makes our current system incredibly inefficient and wasteful.
Exactly.
It's not just a moral problem. The history of unequal access is the economic handicap we're dealing with.
Which brings us right to this almost tragic idea, the economic myth of deservedness. Study after study shows this pattern. Public support for universal programs like UHC goes up when people think the beneficiaries are, hardworking Americans like themselves. But that support drops, often sharply, when the framing highlights racial minorities as beneficiaries. It's like our emotional and historical biases just override clear economic rationality.
And we can actually put a number on the cost of that inefficiency, the cost driven by this history of unequal treatment.
We can. Recent estimates suggest that health inequities, the differences in health outcomes linked to race, income, geography, cost the U.S. economy something like $320 billion.
Every year, $320 billion a year.
And what? In lost productivity, because people are too sick to work or work well, and in excess medical spending on conditions that could have been prevented or managed better with equitable access. That's just lost potential, lost revenue, lost lives. So if you synthesize all of this, the conclusion seems pretty clear. Making UHC actually work in the U.S., or even just making our current system better, requires more than just tweaking policy dials to cover more people. It requires confronting that history. It means making racial health equity an explicit core policy goal. And it means fundamentally shifting the national conversation away from this toxic frame of deserving versus undeserving aid towards one of shared economic benefit, treating healthcare like the infrastructure it really is.
That really feels like the core takeaway here.
Yeah.
Universal healthcare isn't just one thing. It's simultaneously an economic modernization plan. It's cheaper, it boosts productivity, it reduces crippling debt. And at the same time, it's a necessary step in actually dismantling the historically racist political structures that built our current unequal and inefficient health system in the first place.
Exactly. Look, other wealthy countries provide a clear blueprint. They show that UHC is economically rational, that it improves health, and they achieve it for roughly half the price the U.S. currently pays.
Yeah.
So here's the final thought, maybe the paradox for you to really wrestle with. If the United States pays vastly more money for objectively worse health results, if it actively chooses higher costs, financial ruin for its citizens, and lower productivity over the efficiency and coverage seen elsewhere, what non-economic priorities, specifically this deeply embedded history of racialized opposition, continue to drive that profoundly irrational policy choice? That, I think, is the question we really need to answer moving forward.